Okay, good evening everyone. So today I have prepared mainly the questions from hematology, okay, a bit from respiratory system and a bit from the GI system. Okay, let's see how far can we reach, okay? Let's go very slowly and with a lot of discussion in between. Fine, let's start with case number 1. Okay, just like yesterday and day before yesterday, try to solve this, then we are going to talk or give reason why the answer is uh, okay, uh, right or wrong. Okay, anybody?
Sir, it's option B, ALL.
Okay, Majid, right? Majid, why did you say that?
Sir, because he has pallor and mostly it's a 4-year-old boy
Okay,
and some bleeding spots, PTK like this.
fine. So you think this is ALL? Okay, good. So any other student wants to say something? Any other diagnosis you think?
Sir, option D, mediastinal B-cell lymphoma.
Okay, you which one?
Option D.
Option D, mediastinal B-cell lymphoma.
Yes, sir.
Okay, okay. Anybody else? Otherwise, we'll explain this case. Anybody? Okay. Now let me explain about this case. This is a 4-year-old boy, okay, who presents with. Let me use underline. 4-year-old. This age is very important here. Presents with pallor, that is anemia, fatigue, okay, probably because of thrombocytopenia, and painful limp. Now this painful limp, okay, in this case, maybe because of arthritis or osteomyelitis or some bone infection. He has a lymphadenopathy as well, and chest X-ray shows a widened mediastinum reported as a possible mass. So probably mediastinal lymphadenopathy is also there. So if you combine all these things together, according to the age and these things, ALL is the most likely diagnosis because of the age, because ALL is most common. You have studied, isn't it? You have studied that. It is common between 2 to 6 years of age in a male child. A typical feature of anemia, thrombocytopenia, as well as infection. This can be considered as an infection there, infection of the bone or joint. Lymphadenopathy is also there, and mediastinum is also widened. Now, if I go still into detail, probably this is T-cell leukemia, because mediastinal lymphadenopathy is more common in T-cell leukemia. This is how we can give reason in this type of cases. Now, this is a case of ALL. Okay, let's go to the another case. Can you do this, please? Now, here are more than one correct answers.
A and C.
Sir, I will go with D.
Okay.
All trans-retinoic acid.
Okay, so you want to choose only that option?
Yes, sir.
Okay.
Or B, sir.
Okay, Ijaz, what is your answer? You're trying to say something?
Sir, it's A and C.
A and C. So you want to go for A and C. Okay. Any
D.
other? Okay. D also?
Yes, sir. Sir, I will go for
Yes,
A
sir.
and E.
Sir, D. All trans-retinoic acid.
Okay, okay, I got your answer. Fine. Let other students speak. Yes,
Sir, I will go for A and E
A and E.
for broad spectrum antibiotic and that transfusion of blood transfusion.
Okay, A and E. Any other? Okay, now see, we have to diagnose this case first. Okay, then you can choose the treatment. Now let's analyze this. She is a 43-year-old female present with epistaxis, bruising, and menorrhagia for 1 week. Now, these are all bleeding disorders: epistaxis, bruising, and menorrhagia. She is febrile, so there is a component of infection, okay, maybe, and appears unwell. She is diagnosed with malignancy, acute promyelocytic leukemia. Now, this is M3, okay, M3 type of AML, M3. This is an important one. Which of the following are the most important aspects of her initial management? Now, let's analyze this first. This M3 or acute promyelocytic leukemia has one very common complication, that is DIC, disseminated intravascular coagulation, and during the treatment we have to use ATRA, all trans retinoic acid. So D is definitely correct option, but so many others are also correct because she is bleeding from everywhere. Probably this bleeding is because of DIC, and she is febrile also. So I will go for broad spectrum antibiotic also. I'll give platelet transfusion also. I'll give precipitate as well, because this is a case of DIC. Fibrinogen is very low in DIC. D already told. And blood transfusion, it depends. I need to check hemoglobin. So this also you can choose. So this type of question needs proper explanation actually. You should convince to the examiner, okay, why you want to use that. Okay, so multiple answers can be there. So here, first thing is the diagnosis, which is important here. Now they have not even mentioned A actually, see, but there is fever. Okay, there is fever, so we cannot take any chance here. So we need to use antibiotic because this is a case of malignancy. Other explanation you already know. This ATRA is all trans retinoic acid. It's a vitamin A derivative, which is a specific drug in the treatment of M3 type of AML. Now let's go with case number 3.
Hello, sir. It's option B.
Yes, Kedar, is option
B.
von Willebrand disease. Okay, can you give me explanation?
This is 18 years old female patient. She has easy bleeding, which means that the lab platelet is normal and the coagulation factor are normal. On this Willebrand disease, both are normal. The only problem is the platelet is not connected, attaching to the connective tissue. It's like a barrier. So
Okay.
if you have a defect on that, have a normal, those lab tests would be normal, and it's inherited diseases as well.
Okay. Okay.
So
So
I'll go for B.
okay, so you want to go for B. Okay, I'll come to you. That's a very good explanation you have given. Anybody else?
Sir, option D.
Sir, it's option B.
Okay, wait.
Von Willebrand disease.
Okay, you want to go for option B now. Yes, Ilyas, you are saying option D, right? Why? Can you give reason?
Sir, the bleeding is from the upper surface from mucosal, which indicates there is some platelet disorder, while the PT and APTT is normal, which rule out the hemophilia and von Willebrand disease. So therefore, could be option D.
Okay. Now, this is a little bit controversial question, frankly speaking. Option B and option D both can be a possibility here. Now, let me explain you. She is an 18-year-old woman who has a menorrhagia and iron deficiency anemia. This is because of repeated bleeding. Okay, iron deficiency anemia is there because of repeated hemorrhage. She has a long history of easy bruising and epistaxis since childhood, with requiring cauterization, such a severe epistaxis that it required cautery for the treatment. She also bled excessively after tonsillectomy. Her mother bruises easily, so there is a family history as well. A coagulation screen shows are normal PT and APTT. Her platelet count is normal. Now let's analyze one after other. What are the possibility here? Hemophilia. Hemophilia can be easily ruled out once there is normal APTT. This cannot be hemophilia. That is one reason. And another one, hemophilia usually leads to deep-seated bleeding, not superficial hemorrhage. So these all are examples of superficial hemorrhage they are providing. So hemophilia is excluded. This can be von Willebrand disease. Only one point is against that, and Elias has rightly picked. APTT is usually slightly prolonged in von Willebrand disease because von Willebrand factor can act as a carrier for factor 8. Okay, but it depends which type of von Willebrand disease is this. There are different types of von Willebrand disease: type 1, type 2, and type 3. So it still can be a possibility here. Corrective tissue disorder never presents like this. Okay, and D can be a possibility because this is a qualitative platelet deficiency. The quantity is normal, but they have not mentioned anything regarding the quality. So I will go for option B and D here. Though in the explanation they have only mentioned B, okay, but we cannot rule out D as well. They should give some solid evidence there. Let's go for question number 4 now. Have a look there, please. This is 10 to the power 9, okay? 10 to the power 9. I'm sure you know the meaning of this. Anybody?
Sir, option B.
Sir, option. Okay, Ilyas, you go first.
Sir, option B, myeloproliferative disorder.
Okay, can you explain, Ilyas?
Sir, there is the platelet level is above the normal, and also there is leucocytosis, and there is the splenomegaly of the patient, and her blood viscosity is most probably above the normal, which causes the claudication of her vision, which all fits under the myeloproliferative disorder.
Okay, very good. So which myeloproliferative disorder you think this is? Your answer is okay.
Yes, yes,
Yes,
sir. Yes.
yes. Which one?
Sir,
Polycythemia vera.
actually, in myeloproliferative disorder, we have like four category, like thrombocytopenia, leucocytosis, and two others.
Okay. Okay, fine. Your answer is okay. Good.
Sir,
I'll come back to you. Okay. Yes, Mehmet. Yes, yes. You can say now.
and sir, I was also going for B because the age is also a hint here because it all average age is 50 to 60, sir,
Mm-hmm.
for myeloproliferative disorder,
Mm-hmm.
and it looks like polycythemia vera.
Polycythemia vera.
Yes, sir, because hemoglobin count is higher, sir, for this age, and she is female.
But hemoglobin is within normal range. See this? This is normal range. 11 to 15. It is 14 here.
Oh,
Okay. This
okay,
inside the
sir.
bracket, what they gave is a normal range.
Yes.
Okay. Anybody else?
Okay, sir.
Okay, no problem. Anybody else? Okay, let me explain this then.
So,
Yeah?
and sir, one more hint, sir. The blurry vision is also seen in polycythemia vera, sir.
No, no, not a case of polycythemia vera. Okay, so let me explain this.
Yes.
She is a 65-year-old female who have a full blood count, that is hemoglobin 14. See here, the normal range is 11 to 15, so it is inside the normal range. Okay, platelet count is very, very high. This is 800,000 platelet count. The normal range is 150 to 400. It is double than that. This is 800,000. Now WBC is 20,000, so it is high. The normal range is a 4 or to 9,000. It is given. It's according to the different lab. Some lab mention 4 to 11 also. They have done differential count, and that differential count tells us, okay, that neutrophil is 50%, eosinophil 30%, basophil 5%, lymphocyte 10%, and monocyte 5%. What does that mean? All cells are increased. See this, it's a mainly a myeloid series. The neutrophil belongs to myeloid series, eosinophil belongs to myeloid series, basophil belongs to myeloid series, and monocyte also myeloid series. Only lymphocyte is 10%, all others are 90. Okay, so this is an important clue for you I'm giving. And there is splenomegaly of 3 centimeter. She has been having transient clouding of vision in her right eye. This is most probably because of hyperviscosity, because look at the number of cells here. Platelet is way too high and WBC count is also high, so they are causing hyperviscosity. Now the answer is very easy here. There's no doubt at all this is a myeloproliferative disorder. But examiner will not keep quiet here. They will ask you which one of the 4 myeloproliferative disorder is this, and most probably this is a case of CML, chronic myeloid leukemia. Chronic myeloid leukemia. Now can anybody tell me what are the other myeloproliferative disorder? Yes.
Sir, others are polycythemia vera
Okay.
and myelofibrosis
Mm-hmm.
and thrombocythemia, sir.
Okay, very good. Okay, so let me write it so that other students would be benefited from here. Polycythemia rubra vera. Okay, polycythemia rubra vera is the second one. The third one, okay, third one is myelofibrosis. Myelofibrosis with myeloid metaplasia. Some of the textbook even mention it like that. And the last one is called essential thrombocythemia. Thrombocythemia. So these are very essential. Sorry, it's one L I missed. Essential thrombocythemia. These are the four types of myeloproliferative disorder, but this most likely looks like CML. Okay. Now let's go to the another slide. See there, please.
leucocytosis 8 साल 20 साल 28 साल हो गए तो काफी गड्डी है आपा
Yes.
This is option B.
Option
B.
B. You mean autoimmune hemolytic anemia?
Maybe, sir. Yes, sir.
Anybody else?
Sir, option C, alcohol.
Alcohol. Okay. Why you think? Because he's an alcoholic. What else? What else reason you want to give there?
Sir, he is an alcoholic too, and his LFT is deranged. Like alcohol can also cause the liver damage, and he is presented with pancytopenia. So mostly the plastic anemia are idiopathic, but alcohol could be one of the reason. There is hypersegmented neutrophils on the blood film, which suggests of vitamin B12 deficiency, but the serum B12 is normal. So and other thing is the MCV is above 100, which shows there is megaloblastic anemia, while alcohol could also cause megaloblastic anemia.
Good, good. The most of the reason you have given is fine. Okay, very good. I'll come back to you. Okay. Anybody else? Anybody who wants to, say something here? Now, okay, let me explain. Nobody is speaking, so let me explain here. This is a 32-year-old man who is brought in collapse condition to accident and emergency with multiple bruises, smelling of alcohol and extremely unkempt. Means he looks very untidy, probably because of the effect of alcohol. He is pancytopenic with raised INR and deranged LFT. These all are features of alcoholic liver disease, chronic alcoholic liver disease. Okay, this is a very important point. uh, Most probably they have not given other clue, but you need to ask one question here: why this person is pancytopenic? Probably this person has already developed portal hypertension because of cirrhosis of the liver. As a result of this, hypersplenism has occurred, and maybe the person is pancytopenic. Okay, this type of reasoning you should do to yourself. Now, raise INR is because of uh, increased PT. We all know that, and there is a dearranged LFT as well. So liver is already badly damaged. MCV is 125 fem to liter. Now, Ilyas is very correct. If it is more than 100, this shows this is a macrocytic anemia. Macrocytic anemia. There are hypersegmented neutrophils on the phlegm. Now, this tells this is megaloblastic anemia now. Megaloblastic anemia. And there are two important causes of megaloblastic anemia you have studied: vitamin B12 deficiency and folic acid deficiency. Why have you forgotten this? Okay, now see here, serum vitamin B12 is normal, but they have not told anything regarding the folic acid deficiency. So even alcoholic people, okay, they ignore their diet, they suffer from multiple vitamin deficiencies. We can give reason like that. So after considering everything, this is folic acid deficiency. It can be alcohol, okay, but how can you fit hypersegmented neutrophils on the phlegm because of alcohol? Because of this point, the diagnosis should be folate deficiency here. So this is the way, you have to give argument to yourself. You need to ask a lot of questions, and then you can reach to the correct one. Okay, so this is the answer is E. What reason they have given? Alcoholic and the homeless tend to be malnourished, and folate deficiency is quite common due to poor intake of greens and vegetables rich in folic acid. All other points are matching in the diagnosis.
Sarah?
Now, okay, let's do this now. Then it is a break time for us. Okay, please go for this.
Sir, can you hear me?
Yeah, sure.
Sir, I need to just does folate deficiency can cause like some liver damage or
No, folic acid deficiency as such, doesn't lead to liver damage. Okay, no, but because of alcoholism, the person will ignore the diet, and that diet ignorance can lead to folic acid deficiency secondarily. They are explaining like that here actually.
yes, sir. Okay, sir. Thank you, sir.
Okay, so go for 6 now.
Sir, polychromasia mean polycythemia?
No, polychromasia means multiple color. The RBC which are present on the peripheral smear have multiple color. This is the meaning.
Oh. Sir, this is B.
Okay, this is uh, B. Okay, can you explain yourself?
Yes, sir. Uh, he is anemic and jaundice also. So in hemolysis, there is
Hmm.
jaundice. Yeah,
Okay,
and
then.
yeah, and also spirocytes
Hmm.
and nucleated red cells are also seen.
Okay,
So it may be autoimmune hemolytic anemia, and the angina may be due to uh, thrombus. Yeah, which is due
okay,
to polycythemia.
okay. I'll come back to you. Okay, we have given very good reasons. Just wait for some time. Anybody else? Okay, so we just have less than 1 minute. So let me say something here. This person presented with angina. He's anemic and jaundice. Hemoglobin is very low, less than 7. It's called severe anemia. MCV is still higher, more than 100. Reticulocytes is 5%. So if I combine everything together, this is clear cut a case of hemolytic anemia. See this: anemia, jaundice, reticulocytosis. So hemolytic anemia. On top of that, the blood smear is also showing the same thing. Different types of color, spherocyte. This is one of the important feature of autoimmune hemolytic anemia. There are spherocytes present, not only in the hereditary spherocytosis. In this condition also they are seen, and nucleated red cell are also present. Now, I should explain two things here: why angina and why MCB is more than 100. Now, in hemolytic anemia, the bone marrow is working excessively. Okay, I was talking about this case. This is a 60-year-old male presents with angina, is anemic and jaundiced. Hemoglobin is very low, that is less than 7. We call that severe anemia. MCV, mid cell volume, is 106 femtoliter. Reticulocyte count is 5%. So this low hemoglobin, high reticulocyte count, jaundice, strongly tells us this is a case of hemolytic anemia. Okay, so just choose which one is hemolytic anemia from the list. So it is B, autoimmune hemolytic anemia. One test is not given. This is direct cum test. If direct cum test was given, then it would be a even easier choice for us. But nevertheless, polychromasia, spherocyte, and nucleated red cells are other features of hemolysis. This spherocyte is a typical features of autoimmune hemolytic anemia. Okay. Now, only 2 points I need to explain here. Why MCV is high? Now, remember, in many types of hemolytic anemia, the bone marrow is overworking, and that bone marrow is slightly folate deficient. So folic acid deficiency can lead to high MCV. Okay, that is one explanation given. Another one, many of these cells are immature cell, and immature cells are usually bigger in size. This is another explanation. Now, why angina? There is nothing, no association given for angina, but anemia can lead to angina. Remember this. See, look at the anemia here, 6.2. This is severe anemia. So when oxygen carrying capacity of the blood is low, angina can happen. So all of the points we can fit into autoimmune hemolytic anemia. So this is the correct answer. Okay. So the features here are of hemolysis. Okay, so autoimmune hemolytic anemia is the answer here. Let's move on. Let's see another case. Yes, this is very easy case. So I hope some other student will answer this.
Sir, option A, hypothyroidism.
Okay, can you explain, Talha?
Sir, because of sir hypothyroidism, sir, there is weight gain, sir,
Good.
and sir, hair loss, sir,
Okay.
and sir, mild anemia,
Okay.
sir.
Okay. Good. Good. Okay. Good reason you have given. Anybody else? Any other student have different opinion?
Yes, sir. It's hypothyroidism, sir.
Okay. You also want to go for
Sir,
same? Yeah. Yeah.
yes, sir. Because the weight gain is like mixed edema, called mixed edema in this case, sir, and hypothyroidism. Yes, sir. And the lethargy and everything is due to anemia, because mild anemia also occurs in this case.
Okay. So yeah, both of them are right. This is a case of hypothyroidism. A typical sign and symptoms are given. See there, she is a female. Hypothyroidism is more common in female sex, number one. There is weight gain. This weight gain is because of mixed edema. You're right. Hair loss and lethargy are very typical features of hypothyroidism. Very, very typical. Okay. Deep tendon reflexes are reduced. This is another clue given. They are reduced, especially the relaxation phase is very, very long in case of hypothyroidism. MCV is higher. Hypothyroidism is one of the conditions which give rise to macrocytic anemia, though we really do not know what is the reason. Alcoholism, hypothyroidism, vitamin B12 and folic acid deficiencies, these are very known cause of macrocytic anemia. Don't forget that. So these options keep on repeating in your future exam. So hypothyroidism is the cause. Now we need to, they may ask you further questions here. What are the causes of hypothyroidism? So can you tell what are the causes of hypothyroidism, the common ones? Yes?
Yes, sir. Sir, iodine deficiency and Hashimoto's thyroiditis.
Very good. These are the two very common ones. Excellent. Okay. So see here. These are features of severe hypothyroidism. Features of severe hypothyroidism. Let me underline and explain to you. Features of severe hypothyroidism. One should look for an immune cause like Hashimoto's thyroiditis. A mild macrocytosis can be found as part of severe hypothyroid state. So macrocytic anemia can be seen. And the cause is not that very clear. Now, to confirm whether this is Hashimoto's thyroiditis or not, one special autoantibody test has to be done. What is the name of that? Anyone? Which test you do to know this is a Hashimoto's thyroiditis? Which autoantibody?
TPO, sir. NPTPO, thyroid
Exactly.
peroxidase.
Exactly. Okay. So thyroid peroxidase antibody, TPO, anti-TPO antibody. Very good. So see there, same type of cases, a different way the questions can be asked. Okay. Now let's go to another hematology case.
Sir, it is option C, chronic myeloid leukemia.
Yes, Majid, you are saying option C, chronic myeloid leukemia. Can you explain it?
Yes, it's 50-year-old man, and
Okay.
that is PH chromosome,
Mm-hmm.
Philadelphia chromosome.
Very good. Okay. So that's a easy case actually, and you are absolutely correct. Absolutely. So this is a 50-year-old male with lethargy, splenomegaly. Let me explain this. Lethargy, splenomegaly. This splenomegaly is usually huge one, and the following blood count. This WBC is 60,000 here. 60,000, very high WBC count. If they just give this number, you understand that this is 60,000. Neutrophils 55%, myelocyte 25, lymphocyte just 2%, eosinophil 5%, basophil 1%, monocyte 1%, and blast 1%. Okay, so most of the cells belong to myeloid series. Platelets 600,000, very high. So WBC count is also very high, platelet count also very high, and analyze the which type of WBC are there. They are mainly the mature one, neutrophil, okay, eosinophil, basophil, everything is there. Then myelocyte is also considered relatively mature one. The blast cells is just 1%. Hemoglobin 11.5, slightly low, and this is the absolutely important clue for you. BCR ABL translocation, also known as Philadelphia chromosome, is detected by FISH or FISH analysis. This is a genetic analysis on peripheral blood. So what is the correct option? This is chronic myeloid leukemia, C. So just a few clues are enough to make the diagnosis, okay? So this patient has CML with a marked leucocytosis with a myelocyte and neutrophil peak. There is also an eosinophilia, excess basophil, and platelet as well. She has a myeloproliferative disorder with CML being the most likely diagnosis. Philadelphia chromosome analysis or BCR ABL detection by FISH confirms the diagnosis. Let's move to the next one.
Sir, I will go with the option D.
Option D, myelofibrosis. Why?
Yes, sir. Sir, because first of all, splenomegaly is seen there. And it said that bone marrow unable to aspirate because in myelofibrosis we mostly see sir bone marrow is fibrosed, sir, fibrosed bone marrow type,
Okay.
sir, that's why.
Okay, fine. I'll come back to you, okay? Let me get some answers if others are ready. Yes, anyone? So nobody is, speaking. So you are absolutely correct. These are enough clues to say this is a case of myelofibrosis. So 40-year-old male, okay, 40-year-old male, presents with lethargy and very huge spleen. 16 centimeter splenomegaly is a massive one, and myelofibrosis is one of the cause of massive splenomegaly. So from there also you can get certain clue. He has a leucoerythroblastic blood film. Remember this term. Leucoerythroblastosis is a typical features of myelofibrosis. Now what happens here? Because bone marrow is fibrotic, it doesn't function well. So these blood cells are either formed by spleen or liver. So this is extramedullary hematopoiesis, and this is the typical picture. Now bone marrow was done here, and they unable to aspirate the bone marrow. It was dry tap, which exactly happens in myelofibrosis because there is too much fibrosis going on, which is confirmed by increase in reticulin on trephine biopsy. Trephine biopsy is a needle or core biopsy here. So all of these tells us that this is a case of myelofibrosis. These are the very typical type of cases. So see there, these features suggest marrow fibrosis, and the markedly enlarged spleen suggests myelofibrosis. Other causes of marrow fibrosis or leucoerythroblastosis include infiltration with malignancy, usually localized, as well as tuberculosis. And other causes of massive splenomegaly are, you know, these causes, visceral leishmaniasis or Kala-Azar, even chronic malaria or tropical splenomegaly syndrome, uh, Gaucher disease and Niemann-Pick disease, which are called lipid storage disorder, and even portal hypertension. These are other causes of massive splenomegaly. Let's go to number 10. This is platelet 20,000. Okay, so this is actually wrongly denoted here. 20,000. Yes, anyone?
Sir, I will go with ITP, but I'm confused.
Okay, you think it's ITP,
Yes,
but
sir.
you are not sure, right? Okay,
Yes,
no,
sir.
no problem.
But
So maybe,
the reason which I'm going for ITP is decreased platelets, sir.
okay,
Platelets are very decreased, sir.
okay, okay.
And in ITP, the decreased platelets, like the lower range platelets, will be less than 50,000.
Mm-hmm. Okay.
And here it's very much
Yeah,
decreased, sir.
yeah, it's 20,000. Okay.
Yes,
So
sir.
anybody else? Any other student?
Sir, option B, ALL.
Option B, ALL. You think it's ALL? Can you give reason?
Sir, when the age is also suggested when the patient is having pancytopenia, and
Mm.
also the patient is having hepatosplenomegaly, which rule out a plastic anemia,
Mm-hmm.
and there is some small blast cell which is also present in ALL, while the myeloid marker are not detected, which rule out AML. So while ATP doesn't present like this.
Okay, so you strongly think this is ALL. Okay. Okay. Anybody? Anybody else? So other students are they just uh, connecting and disappearing somewhere, or are they still here? Nobody is speaking actually. What about my African students? Are you still here? Let me check. Okay, so maybe they don't want to participate. So 3-year-old boy, 3-year-old boy. So age is very typical for ALL. Okay, Elias is absolutely right. With bruising and irritability, these are symptoms. Bruising because of thrombocytopenia and irritability because of anemia. He has a white cell count of, this is very high white cell count. Okay, see here, this is 100,000. 100,000. So WBC is high here, but hemoglobin is very low and platelet count is also low. This is 20,000. So this is a little bit denoted in the wrong way, 20,000. So hemoglobin is low, severe anemia, severe thrombocytopenia, but high WBC, and hepatosplenomegaly, very typical features. A blood film is shown a monomorphic population of small blast. So blast cells are also present with no granulation and scanty cytoplasm. This is very typical of lymphoblast. In myeloblast, there is plenty of granules inside, and in myeloblast, the cytoplasm is also a little bit more than lymphoblast. Remember, lymphoblast are rounded cell, and cytoplasm is almost filling, nucleus is almost filling the whole cytoplasm. Now, myeloid markers are not detected. This is another clue which tells this is not a case of myeloblast or AML. So all the points are in favor of ALL. Now, why this is not a case of ITPC? Only platelet, okay, is decreased, uh, which is in favor of ITP. How can you explain this high WBC here? How can you explain blast cells here? Okay, why they give this different hint for you? So ITP never present like this. ITP presents only with decreased platelet but not with other type of features. So here today we have seen two different cases of ALL, so presented in a different way. So let me go through this. This child has ALL with marrow failure as a result of infiltration with lymphoblast. Okay, our rods do not occur in ALL, and all these marker for AML will be absent. Now let's go to case number 11.
Sir, I'll go with Burkitt's lymphoma.
Burkitt's lymphoma. Okay, okay, Shidhu, like, can you give reasons here?
Yes, sir. The starry sky pattern is the pathognomic for Burkitt's lymphoma, and it is mostly associated with HIV positive patients.
Okay, good, good. So you are absolutely correct. Okay, very good picking. This starry sky pattern is highly typical of Burkitt lymphoma. If you see this description, without any doubt, they are talking about Burkitt lymphoma. But still, let's talk a little bit about this, because sometimes they may not give this typical pattern, and still you need to diagnose. Here is a 45-year-old man who presents with back pain, night sweat, weight loss, and 10 centimeter retroperitoneal mass. Now this is a Burkitt lymphoma mass. Now remember, Burkitt lymphoma is a type of non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma can occur commonly in 3 different areas. One is head and neck, another is thoracic cavity, okay, or inside the mediastinum, and third is in the abdominal cavity. So this is abdominal type of non-Hodgkin's lymphoma. He has a markedly raised LDH, which is a feature of any malignancy, and his HIV result returns as positive. See here. So this person is HIV positive, or probably in AIDS. HIV and AIDS, one of the manifestation is non-Hodgkin's lymphoma, like Burkitt's lymphoma. So we can consider that as a AIDS defining illness also these days. And the most important clue is this one, starry sky pattern. Okay, so without any doubt, this is a case of Burkitt lymphoma. Let's go through what they have given here. These features suggest Burkitt lymphoma, a highly aggressive and rapidly proliferating mature B-cell tumor, hence the high LDH. This is lactate dehydrogenase. This is intracellular enzyme. If a tumor is highly proliferating, it will leak outside and raise in the blood. It has a strong association with HIV. It can present with abdominal mass, a rapidly enlarging lymphadenopathy, and B symptoms are often present. Okay. Now, one important question: what is the cause of Burkitt lymphoma? What is the cause? Which virus causes Burkitt lymphoma?
Sir, Epstein-Barr virus.
Okay, Epstein-Barr virus. Very good. So let's make this as a last case for today. Okay, please go through this.
Sir, it's option A, Horner syndrome.
Okay, can you explain it?
Yes, sir. The left pupil is small It means that the pupil is narrow
Okay.
and the eyelid is drooping,
Mm-hmm.
which is seen in Horner syndrome.
Okay, good. So you think this is Horner syndrome. Okay. So any other student? I'll explain. Okay. Wait.
Sir, option C, ED's people.
This is Eddie's pupil. Can you give reason?
Sir, I rule out all the other options. Like Turner syndrome, there will be anhidrosis with it. In Turner palsy, why there is wasting of small muscle. While
Mm-hmm.
in the opioid there will be loss of consciousness and respiratory
Mm-hmm.
irregularity. While in the Argyle Robertson pupil, like the pupil, the Argyle Robertson pupil, there will be history of syphilis and there will be non-reactive pupil to the light. So the
Okay.
one option is missing.
Okay. So wait. Okay. So any other student? Okay, so let me explain this. This is the last case for today, and we don't have enough time also. Okay, fine. Now see here. Sorry. This is a 65-year-old man who has a small left pupil, and the eyelid on that side is drooping. Now let's analyze one after other. Very old person. Small left pupil. This is meiosis. Okay, meiosis, and the eyelid on that side is drooping. This is ptosis. So we have two component of Horner syndrome. If Horner syndrome is the answer, we need to start accumulating the evidence, isn't it? This is the way. He was also noted to have wasting of the small muscles of the hand on the left. Now, according to Elias, he could not fit this into the Horner syndrome, isn't that? If you have fitted this into the Horner syndrome, then your answer is A, right? Yes.
Yes, sir.
Yes. Now we can fit this, What is the cause of Horner syndrome? What is the common cause of Horner syndrome? Just go there now. What is the common cause?
Stroke.
Look at the look at the age of this patient.
Stroke.
Bronchogenic carcinoma, okay, or carcinoma of the lung, especially if this has occurred towards the upper lobe. Now, that can easily cause destruction of those sympathetic ganglia. At the same time, it can also damage the brachial plexus, okay, the brachial plexus. So now, small muscles of the hand are supplied by ulnar nerve, and ulnar nerve originates from C8 and T1, okay, root value of the brachial plexus. This is how we correlated. This is a little bit difficult case, not straightforward. Horner syndrome is the answer here. Other are very, very difficult to fit. See that Thorner palsy, okay. Now Thorner palsy, how you explain this wasting of the muscles of the hand and the feet, isn't it? And this small left pupil doesn't occur in Thorner. The opposite thing happened, dilation, so excluded easily. Okay, opiate overdose, pinpoint pupil on both sides will happen, and other things are very difficult to explain. R.J. Robertson pupil, you're absolutely correct. They didn't give any clue for the light reflex or accommodation reflex or something like that. No history of syphilis. And Addis pupil is tonically dilated pupil, which very slowly reacts to the light. And this occurs because of damage to the postganglionic parasympathetic fiber. Okay, so this is not the case here. This is Horner syndrome. So let's show you that answer, and then I'll stop for today. See here, this man has a Horner syndrome. Ptosis and pupil abnormalities are associated with Horner syndrome. Small pupil and Thorner palsy, large pupil. That another explanation they have not given, but that's how we should fit to the diagnosis. Okay, thank you very much.